Hi guys, my name is Gregory. I'd like to discuss a case being posted on CERIC Doctors. A beautiful case, by the way. Nathan did a beautiful job. I could do myself, honestly, what he does. But we are here just to have, I'll say, positive criticism about this case. So I want to follow what I see so far. I don't have the whole case in front of me. I don't know the patient, but let's speculate probably what can be done better. I know a lot of people question me. Is it constricted chewing pattern? Is it something else? Is it dysfunction, friction? What's the difference between those diagnoses? So I'm gonna just explain to you what I see so far, and then if you can comment on a discussion board, it would be grateful, so we can probably all benefit from this case. As you can see here, that the patient has a lot of erosion, not just from outside but from the inside. So most likely that the patient has some kind of chemicals problems, maybe diet or something else. But if you're going to look from the lingual point of view, you can see there's a lot of erosion on those anterior teeth. And most likely, the people question me that says, is it constricted chewing pattern, friction, or is it erosion or dysfunction? What's the differentiation between all of them? So as you can see here, that we see also that's erosion, but also this island of enamel. And as also you can see here, it's a little bit erosion, like a friction. The point is, what I see so far, it's most likely just the erosion problem, not a occlusal problem at first, but it's like a perimyellosis on this patient when people trying to suck against the front teeth, like a taste the food. Just saw a patient of mine that's had the same problem, and she was admitting that she has this kind of problem. So some people have kind of habits to suck on those front teeth, and the tongue working like a sandpaper. And besides the acidity, it's also destroying the enamel on the palatal area, making the incisals very thin and fragile. If we can proceed this case from the model Nathan scan, you can see here clearly that's the island of enamel missing, but some of them island of again enamel present here. You can see a lot of erosions also on posterior teeth, especially premolars. See some defect on composite, because acidity usually destroys the composite filling. But if we going to look at this from the bite, as you can see, there's a deep bite, but only mostly on the front area. And you can see maybe OVD is still present on this patient. And the only defect that's the teeth people have, it's usually an anterior area. And if we going to look at this from just put lines from the gingival perspective, we know it's from aesthetic point 6, 8, 9, and 11 should be in one level. As you can see, there's a passive eruption due to erosion. The teeth start moving down. But if you look at the low anterior teeth, you can see clearly how much they moved up. And also start creating a little bit more of a friction on this kind of area. So if my guess would be what this is diagnosed, mostly it's erosion and that the teeth moved. And I think would be a space. I ask Nathan probably to send me a case so I can see like an interocclusal space and anterior teeth. I think it will be still like an island of air space between them. So there's definitely not a dysfunction. If you're going to just hand models those upper and lower, you can see there is no way that it moves the jaws will move freely. I think it's mostly, I would say, just a friction, if this would be the case, but not, I would not say constricted. But again, I don't know the patients, I don't know the history. I would probably ask a lot of questions. So the difference between the friction and constricted chewing pattern: on the friction, there's no MIP is still working, and there's a friction on just anterior teeth. The lower jaw doesn't move back compared to constricted chewing pattern. Okay, so the people usually in dental history will mention that when they bite, they feel like a lower jaw moved back. As Mike Scramsett said, that you probably have to do a deprogrammer. You can do the deprogrammer here. That's if you feel some questions about it. It's nothing wrong with it. You can probably maybe deprogram right in the patient's in a chair, and if you see if there is a repeatable spot at the same time, so people don't have to leave with the deprogrammer for 7 days. But otherwise, again, if you deprogram him right at the chair, it will be much easier to assess the area, to see it's actually the jaw moves anywhere. Okay, so Nathan also presented, he designed, and he said that he wants to move the restorations out of the palatal damage from erosion and make a little bit smile better. But I would say that if I would take this case myself, and if I see the patient lost the enamel approximately maybe 1.5 millimeter on a palatal, and you're trying to move the restorations more on the buccal area, so I have to grind more palatal just to fit the restorative part. So I would probably do more damage with the restorative part than patient did all these years. Okay, so I would probably be more conservative, but again, Nathan did what he could in this particular case. So as you can see here, that's when he designed, it's on an in-lab most likely. The design that's he designed restorations more buccally, and he also probably, according to what I see so far, he increased the length of the teeth more incisally. He tried to probably remove the pathways of the future restorations, make sure there's no constrictions on them. So the question would be, do I do ortho or not? So again, you have to evaluate. Probably ortho would be the best case to move the teeth more, let's say, intrude them, upper and lowers, create a space for restorative, then restore them with conservative preparations. But if OVD would be allowed probably to restore this, it's very easy to do. Just I'm going to show you this on the diagram. So you can see here that if you put a little bit composite between the 8 and 9, okay, with the flat surface towards the lower anterior teeth, okay, just squeeze a little bit composite, okay, use your the instruments, make it a little bit flat, cure, okay, you don't have to bond, and then let's make it flat and make the patient's bite. It's like a deprogrammer but the chair side, and make sure you have only one spot, as you can see this on diagram, okay, and make sure it's a repeatable spot. When you achieve this repeatable spot, you also can add the composites to the OVD, okay, or how much you want to increase the OVD, okay, visually and according to facial generated treatment plan. So when you achieve that result, so increasing your OVD, repeatable spot, you got this between 8 and 9. It's going to take you maybe 20 minutes the most, okay, if the patient is deprogrammed, there's no occlusal problem. And then what you do next, you will take a flowable composite, okay, and you add on those premolars, you can see here on both spots, okay, and put the composites and make sure they are touching the lower lower teeth in the fossa. So you're working on the working cusps. You can do the same on the buccal cusp on the lower lower premolars. to establish the OVD. And then you continue just on a second premolars. If you can add the molars, you don't have to do a lot of composite, just a little bit dots. And now you establish OVD. You can scan this patient, or you can start prepping the teeth according to this new OVD. And now you're creating this space interocclusally. So make sure that so you have enough space for restorative. That's what I would probably do in this case, okay, just to be more conservative. So what I did so far, I outline if Nathan probably wants to increase the length of anterior teeth. You can see the outlines. This will be like a mock-up, and also the reference for my technician if he wants to do the wax-up. With this diagram, that's what I did also. I overlap this two pictures. It's before and after, and you can see how much he added to the incisal edges, and also sorry guys, moved the teeth buccally. Sorry guys. So what I see so far, that would be my reference point if I do the mock-up, how much I have to prep those teeth. Okay, so if we're going to look at the different slide, I also overlap the before picture and also the prep picture. If I see through here, it's I don't know if he used the mock-up, but you can see from all these pictures that's the preparation is a little bit over prepped, especially on all anterior teeth. You can see that's and I will probably point it out on different slides, would probably be done bit differently. So this slide, it's what he presented. I think it's what's probably after the insertion, what he said probably on discussion board. But what I done is to put, again, I took a diagram of his existing teeth and also overlap with preparation. As you can see here, that's how much tooth structure been taken away, and especially on number 9. Okay, I would probably be more conservative with the prep and also with the line angles, especially in interproximal area, so make sure I can close the spacing. Okay, and I will not put a lot of pressure on the gingival on papilla. So if we going through his screenshots picture from when he designs, you can see his design, how much tooth structure been taken away, especially on number 9, as I mentioned before. I will be much more conservative, especially incisally. Okay, but I mentioned the reason probably it happens to him because he tried to probably fill that space when he prepped the specially palatal, and took so much away also the incisally. That's what probably happens to him, and the preparation became a little bit more aggressive. If we looked from a different side, again number 10, as you also can see how much tooth structure been taken away, especially incisally. If I would be conservative, again, the patient already lost the incisal edge, I would have to add. I would probably leave it at the same edges what I see on the pre-op pictures without removing more. So that's what I usually do. So I evaluate before I start prepping the teeth, how much tooth structure I have to take away, what's going to be left. Do I do more damage to the patient's teeth, or I recover them more? Of course, you can't leave this patient with this erosions what he had. But what would be probably the best option for me is to restore it. So I would do this case is what Nathan had a struggle with, because the patient can't afford or doesn't want to sit in a chair for a long time. I would probably mill this in a Cerismart, that's a hybrid materials, as for example 8 and 9. Okay, I would leave it as is, then I restore, then I prep 7 and 10. Then I'll look at the general pictures. In my design, it's what I design is that's what I want. That's anything I can do. And I'll work with this hybrid materials, maybe add the composite somewhere. Okay, and then we'll scan and scan this my temporaries as my final preparation, my final restoration, and then copy and paste in my InLab or ExoCAD software, so that I can deliver the same type of restorations. I will not probably deliver permit 1, 8 and 9, then I'll do 7 and 10. But again, what he did, again, beautiful case, but that's what I would do differently. This case again, what he presented, it's probably after the insertion. Again, it's if I will take the outline of number 8, copy and paste and revert it's the same outline, you can see 8 and 9 shape are totally different. Okay, and especially you see on the distal area of number 9. I know originally number 9 a little bit more inclined. Okay, that's why you have to think it's how you're going to prep, so make sure that you can deliver the restorations in fix this misproportion before you deliver. If I would probably put a long axis of the teeth on 8 and 9, you can see it's totally different. Okay, and on number 9, you can see the line is different angle where the long axis comes with it. So again, when I prep the teeth, I want to make sure it's when I prep and direct my preparation that way, so it'll be easy for my technician or myself to restore it. Otherwise, it's very difficult prepping this teeth and then restore it, and then it became a little bit like a misproportion. This would drive me crazy myself. So that's what I would probably pay attention to the next time if you start prepping the teeth. If we look at 7 and 10, you can see the 7 and 10 is completely totally from different patients. Okay, if I will take a line angle you did beautifully on 7 and 10, they're all different angled, and also the shadow is totally different. You see they're all the same size, but you can see the difference between them. If you're going to look at the long axis of 7 and 10, that also different. So I would probably pay attention a little bit more, I would say, not a copy, a little bit different 7 and 10, but more will resemble. If you look at the weights 7 and 10, they're also different. Okay, I also can see from this picture that's 7 and 10 a little bit more out compared 8 and 9. So if you want to add to the buckle, I would probably make sure to my buckle even with the rest of the restorations. You have enough space to place the restorations with more buckling and make them more even. That's what what I see so far. I think it's number 8, a little bit more out compared to number 9, and number 9 a little bit shorter than number 8. That again, it's my perception so far. If I look at the 6 and 11, it's totally different teeth, totally different inclination, the design. I would probably work again on those designs to make sure they also look the same, and the interpressible incisal embrasures, I would probably work on them also. The tissue, that what bothers me from when I look at the final pictures. I'm not sure it's 6 months, 3 months, but you can see that the tissue is a little bit not happy, not healthy. I think it's they a little bit more squeezed between. I think it's was low crest tissue maybe on all those teeth, but you can see how the tissue have like a little bit like a scar tissue on them. So if what he presented said 6 months after, you can see there's spaces again, black triangles. I'm not sure it's again if I'm following the same slides. So let's go with the preparation themselves. As you can see here, it's especially 8 and 9 are completely totally different. They have to be the same. Okay, 7 and 10, they also have to be the same preparation if you follow again the matrices you propose. And if you look at from preparation, you also can see the undercuts under those distal areas, mesial on number 8 and the distal of number 9. The reason probably Nathan is a right-handy dentist, and when he leans the bore, again, you can see I have the ditching on the preparation. So I usually pay attention to my angulation of the bores, and you can see a little bit undercut. Also, you can see that it's a little bit over prep on the buccally of number 10. So it means also that you taking a little bit more of unnecessary tooth structure on the buccal, the area. And you can see also there's a J margin at the end. What it means also that's the diameter of your diamond a little bit smaller than your shoulder. So to correct this, I usually take a little bit wider diamond and remove this a little bit ledge on these restorations, on this preparation, I'm sorry. This is what he presented again from the palatal. I would probably remove a little bit more palatal on all these preparations, just create a little bit more space, okay, for restorative. That's what my positive criticism. Hopefully it will help you. It's with the next case, we're all making mistakes. As Koi said, there's no there's no best dentistry when there's no dentistry at all. So what I probably suggest you probably use a little bit of matrices and just do it slowly when you prep. Make sure it's you following that's in nature, and make sure it's when you I would say try to probably take the impressions. Try to probably also not to push the tissue a little bit away, so it will not be look like a bitten, and it will heal much better and much faster for this patient. Guys, thank you very much for your attention.